To summarize, an adequate device technique is very common. Teaching and correcting device technique is important to improve disease control and patient outcomes. Relying on written package inserts is insufficient. Healthcare professionals themselves need to be knowledgeable regarding correct technique to be able to teach patients. So, teaching device technique to patients is clearly important. What is the best way to teach patients correct device technique? Unfortunately, there is not adequate data available to know for sure. Based on what is known and our professional experience, we are suggesting a framework of the following key components. Plan for an effective session. The actual device instruction itself, which consists of several parts. Brief introduction and rationale. Demonstration of correct technique. Patient practice with feedback. Provide written or other educational materials. Provide other necessary information about the medication. Summary and closure. Situational modifications to instruction sessions. Importance of reassessment and repetition. Documentation and plan for future follow-up. We will discuss each step and then provide a simulation of an actual patient encounter. Plan for an effective session. A little time up front can help the patient session go smoothly and quickly. First, verify the appropriate device medication selection. Consider the disease algorithm. Is the patient on the right step of therapy for disease severity? In asthma, an inhaled corticosteroid is first line for control medicines, whereas in COPD, inhaled corticosteroids are reserved for later in the disease process. Stepping up or down on therapy could require changing or adding another device. Perhaps the medicines could be combined into a single device instead. Healthcare professionals counseling patients should be knowledgeable regarding the treatment algorithms from current disease guidelines. In the companion videos, we discussed which medicines are available in the various devices. Is the medicine in this device still necessary? Respiratory medicines may be prescribed on a trial basis. If there was no benefit, the medicine might be changed or discontinued. A medicine may have been started for symptom relief until further tests are completed to confirm a diagnosis of asthma or COPD. If another condition with similar symptoms was diagnosed, such as heart failure, sleep apnea, or a restrictive lung condition, the medicine might also be discontinued. Sometimes quick relief medicines are prescribed short-term for wheezing after acute viral or bacterial infections. If that condition has now resolved, the medicine should be discontinued. If a patient would be using multiple devices, also check for duplicate therapy. Some devices, for example the discus and some MDIs, may include a combination of drugs, making duplication of drugs easy to miss. Finally, the patient should be informed if the new medication replaces or is added to current medicines. Commonly, patients will assume they are to discontinue the first medicine when a second is added. Consider if multiple devices need to be reviewed during the session. Are there any disease severity and patient-specific factors that might affect device selection? Some drugs in all drug classes may have more than one device option available. For example, a dry powder and metered dose inhaler. Drug efficacy must be considered, of course, but often there is some latitude in device selection. Those with severe COPD may have difficulty with rapid inhalation or breath holding. Nebulized medicines, despite their expense, may sometimes be the best option. Physical impairments such as poor eyesight, arthritis, and poor manual dexterity may make some devices more difficult to use than others. Consider if the patient's age may impact device selection. Children may be old enough to transition from nebulizer therapy to inhalers with or without masks, or to dry powdered inhalers. Transitioning devices as children grow was discussed in more detail in the metered dose inhaler video. Patient preferences and devices should be considered. When a new medicine is prescribed, a patient may wish to stay with a familiar device. For example, if one is already very comfortable with a metered dose inhaler, prescribing a controller medicine and an inhaler may be preferred to using a medicine in the same class and a dry powdered inhaler. On the other hand, if one is having trouble with the technique for the current device, this could be a good time to change. This verification process identifies which instruction might be unnecessary because the medicine should be discontinued, or if instruction for a different device might be more appropriate. Next, consider how to tailor the session to the individual patient. First, what is the patient's health literacy level? As previously mentioned, inadequate health literacy is very common in the U.S. Predicting low health literacy based on an individual's patient's characteristics, such as income, ethnicity, or educational level, is not reliable. Tools measuring health literacy, such as RELM and the newest vital sign tests, have been validated in clinical studies, but these can be awkward to integrate into a typical patient encounter. We currently use the Single Item Literacy, or SILS, screener. It is also validated, but only involves one question, which can be easily slipped into the conversation. There are a couple of SILS questions to choose from. We use, how often do you have someone help you read the written materials about your medications? If the patient answers often, usually, always, they are at risk for low health literacy. These responses signal the need to allow a longer time for instruction and may influence the type of educational materials to give the patient afterwards. We ask all of our patients a SILS question and record their response in Dashboard in the social history section of their electronic record. This way, the question does not need to be asked at each visit. Also, document patient preferences for learning materials, such as internet sites or videos. If a patient usually likes additional or higher level information, it is good to record that too. Next, is the patient knowledgeable about this specific device already? Check the records for prior prescriptions and instruction with this particular device. If this is a new prescription, has this patient been prescribed a medication using this or a similar device before? If a patient is already familiar with the device, the emphasis for the session can be shifted to assessing the patient's skill with this device versus providing new information. Note which steps the patient had difficulty with in the past. Plan to watch these particular steps more closely. If the patient was already given written educational material, they may not need to receive it again. Also, what is the patient's level of cognitive function? Those with memory impairment or younger children may require more time to learn new information. Elderly patients in general also need a longer time to process information, so plan to present new material more slowly. The answers to these questions will help estimate the amount of time for instruction, plan the approach, and select the type of educational materials to provide afterwards. This planning might only take a few seconds, but can save a lot of time later.